morning, everyone. My name is Kyla, and I am going to be, I'm here with my beautiful assistant, Maria. We are going to be showing you a comprehensive head-to-toe assessment. We're going to be talking about preparation, what we need to do if this was a real patient in the clinical setting, and I'm going to go through and show you body systems and how to assess your patients. So prior to your assessment of the patient, you want to grab their medical record, and you want to do a thorough look over so you kind of know what to expect when you're going into the patient's room. If you're in the clinical setting and you're working in a practitioner's office, you want to be sure that you look at the chart. Is this a new patient, or are you doing a follow-up on a patient that you see often? Just to familiarize yourself, because after, as I'm sure most of you know, after you've seen 10 patients, they all kind of blur together. So you want to be sure that you're assessing and you have a good kind of understanding of the patient that you're going in to see. So after I've done that, I've looked at my chart, I'm going to gather my supplies. So for a complete head-to-toe assessment, you're going to need a vital sign machine, which I have here, and we'll walk through what vitals we're going to be taking. We're going to gather things for a good neurological assessment. You may need some cotton swabs, a tongue depressor, you're going to need gloves, of course, your stethoscope, a pen light, what else am I going to need? Kind of like a shopping cart. You're going to take all the things you need with you. Because it's really important to have all the things that you need in the room as you're assessing your patient, then to stop in the middle of your assessment, go get your supplies and come back. You want to be as prepared as possible. We do have an otoscope and an ophthalmoscope on the wall over there. I have a scale here if I needed to weigh my patient. If you're in the hospital setting, most beds, you'll be able to weigh your patient that way. So once you've gathered all your supplies, you're going to come in. Of course, you're going to wash your hands, which I would absolutely do at the wall in the presence of my patient. I wash my hands, and you can put on gloves. Now, if you're in the hospital setting and you're just doing maybe a well visit, and you know your patient, for their comfort, you may not put on gloves. I know a lot of practitioners feel that way. I always educate the importance of wearing gloves, because not only are you protecting your patient, but you're protecting yourself as well. So I will, sorry there, Maria, hand sanitizer somewhere. I will wash my hands. And of course, you can sanitize or wash based on your company's standards. Nothing beats good hand hygiene. However, for sake of our demonstration here, I'm just going to go ahead and hand sanitize. I'm going to put on my gloves, and I would start my assessment. So I would collect my watch cover. I would assess my vital signs. So in this case, I have a digitalized automatic blood pressure, heart rate, pulse ox, and temperature machine. So I would use this appropriately. I would make sure it's in good working order. Always make sure the equipment that you're using does work properly. I would have checked this outside of the room, because I do want to do all the things I can do outside of the room done before I come into my patient's room. So anything that I'm using that's equipment, I would be sure that I have assessed and made sure that it is in working order. But I would, excuse me, take a temperature, which I have here. I would do a blood pressure. I would do my pulse, and I would do my respiratory pulse ox. And I would also look at the available cuffs that I have to me and make sure it's appropriate for my patient. So for example, you always want to be sure that your cuff is the right size for my patient. I want to make sure that it is 80% circumference and 40% width, and that it falls within my index lines as I'm measuring. So in this case, it certainly does. Make sure my arterial line is by the brachial artery in the elbow here. And I'm going to go ahead and I would attach, I would hit the button and take the blood pressure. So once I have a good set of vitals, heart rate, blood pressure, pulse ox, and respiratory, and temperature, I'm going to go ahead, slide my machine, disconnect, slide my machine off, and talk to my patient. So I myself always start with the easy things as I walk into a room. I would knock on the door. I would make sure, of course, before I started any of this, that privacy was maintained, which I do have because I closed the curtain. I would make sure that my patient is comfortable, and make sure the room is comfortable. In our case, the room's a little cold, but that's okay. I would adjust it as able. I could get her a blanket if we needed it, and I would start my assessment. So I would say, hi Maria, my name is Kyla. I'm gonna be your nurse today. I'm gonna do a quick head to toe assessment on you, okay? I would make sure I would check and see how are you feeling today. Do you have any complaints, anything you want to talk to me about? And I would have done this, I'm so sorry, I would have done this prior to my vital sign assessment. I could, or if I'm working in a doctor's office, somebody else may have got my vitals for me. So either way, as long as you have a set of vital signs before you start your assessment, that's the important part. Before I start physically assessing, I want to have those vital signs. All right, Maria. I would like to wash my hands, and I would have done this again before I did all my gloves and all that things, but I would wash my hands and I would ask you your questions. As I'm washing my hands, I can say, how are you doing today? Do you know where we are today? What's today's day? Because I do want to check my A&O status. I'm looking for person, place, time, and situation, okay? You would give me your name, your birth date. I would ask you where we are, what today's date is, and why are you here? So we would do all of that. And then I'm just gonna say, Maria, I'm going to start my head to toe assessment on you. It's gonna take about 30 minutes. Do you have to go to the bathroom? I would make sure that my patient has voided before we start the assessment, because that can skew your results. It can modify your blood pressure, your vital signs. It can cause discomfort during the exam, so then the patient is trying to rush it through, or you may get erroneous results when you palpate on the abdomen. So if you don't have to go to the bathroom, we're ready to get started. Nothing I do should hurt you, and if it does at any point, please stop me immediately and let me know. And speaking of pain, are you in any pain right now?
No.
Okay, perfect. So we would start exactly like it says, head to toe. And now, while I'm washing my hands, while I'm doing my vital signs, while I'm doing all this pre-work with my patient, I have done a lot of inspection already. Everything that I can see of my patient, which in this case, my poor little patient's all wrapped up like a little burrito here with all of her layers of clothing. But I would be assessing for, does my patient follow commands? Is she able to speak to me? Does she track when she speaks to me? The things I can see, does she appear to be in any respiratory distress or any kind of distress? Is her clothing appropriate for condition? Is her demeanor appropriate? I would be looking at skin color. Is it appropriate for ethnicity? I'm looking for any visible signs of wounds, scarring, lumps, bumps, contusions, anything like that. This patient seems relaxed. She seems pretty comfortable. She doesn't appear to be in any distress. So I feel confident and comfortable starting the assessment. So I'm gonna start at your head, Maria. I'm gonna just take a look. I'm looking for hair distribution. Lice. I'm looking for lice. That's what everyone always wants to look for, right? Do they have lice? I'm checking for hair distribution. I'm checking for hair color. I'm checking for any kind, signs and symptoms of any bumps, lumps, contusions, any discoloration, any bleeding. Like she said, any infestations of lice, scabies, anything, ticks, anything like that. So I would look through all of her hair. She's got long, beautiful hair. I would pull it up, look in the back. And so while I'm looking at everything here, I'm looking to see if she, since I'm at the hair, I'm looking at the ears as well. I can assess for any drainage, any lumps, any redness, anything on the ears. So I can do that. And I'm also looking at her face. Does it look symmetrical? Excuse me, I'm looking for her eyes. Again, does she track? What do her eyes look like? In Maria's case, she's got a little redness in that right eye. I've already spoken to her. She says she thinks it's allergies. I would further assess for maybe pink eye or anything like that, but there's no drainage, nothing like that coming from the eye. It's not, she says it's been going on. She takes some Allegra and it feels better. So I'm looking for hair distribution on the eyebrows and the eyelashes as well, because some of our patients, psych patients especially, can pull that hair out. So I do want to keep a look at that. Also, sometimes patients that lose eyebrow hair, scalp hair, or eyelash hair could have a protein deficiency, could be all kinds of reasons. So we want to assess for hair distribution. So now that I've done a good job looking, I've looked in her eyes, there's no discharge. I looked at her nose, no discharge. I could, if I want to continue on the realm of inspection, because I myself like to assess that way. I want to do all of my steps in one body system and then move to the next. I like to do all of my assessment first, so I might have her, I would get my tongue depressor if I have one. Unfortunately, I do not, but if I did, I would pull out my tongue depressor and I would do all my visualization now with my pen light. So I could, sorry, I have something in my mouth. So I could start with her eyes. I'm going to say, I'm going to dim the lights, and I'm going to have her go ahead and rest your head back, dim the lights, and then I'm going to do my assessment for PERLA, which is pupils equal, round, reactive to light and accommodation. So I'm going to take a look into her eyes, checking for my dilation. In her case, what I'm looking for is to make sure that both pupils constrict and relax at the same time, dilate. Constrict and dilate at the same time. I want to be sure that they're both round, which they are. They're both the same color. Reactive, they're both reactive. They both, when I shine the light in, they both constrict and to light. So, and the accommodation piece is, all right, Maria, I'm going to have you take a look at my pen light. Follow it just with your eyes, not with your head. So what I can do now, since I'm going to check my accommodation, I'm also going to check my cranial nerves. Excuse me, so I can do 3, 4, and 6 all at the same time. I'm checking for eye movement, and I am checking for accommodation. So accommodation, I'm going to have you look at my pen light. I'm going to bring it all the way in and bring it all the way back out. And as I bring my pen light into my patient's nose, and I'm about 12 inches away, as I bring it in, both of their eyes should converge, they should come together. And then as I take my pen light out, they should come back to normal position. And hers did. And now, since I'm already here and we're already doing this, I'm gonna say, okay, Maria, follow my pen light. We're gonna go to the right, back, left. We're gonna go up, down, diagonal, up one more, and diagonal. Okay? So again, I've checked cranial nerves 3, 4, 6. Eye movement is intact, so her cranial nerves are intact. If I wanted to check cranial nerve 2, I would give her a piece that I could use a Snellen chart, which most, if you work in a doctor's office, you may have, but most hospitals do not have those in each room. So if I was in a hospital, I could say, okay, Maria, can you look at the clock and tell me what time it is? Because I do want to gauge about that 20-foot-ish distance away for my patient. And if she was able to tell me the time, she could see it appropriately, I would absolutely say that cranial nerve 2 is intact as well. So again, since I'm doing my inspection, I'm doing all of the things that I can see first. Now I'm gonna have her open her mouth. All right, Maria, go ahead and just relax. Say, ah. I'm looking in the back of her throat. Again, this would be a great opportunity if I had a tongue depressor I could use. I can see that she does have her tonsils. They are intact. They are, I would definitely call them like a 1+. They're not touching. There's plenty of space in there, so I'm not worried about that. Say ah for me again. I'm looking for the uvula and the palate to make sure that it does move. When she does that, go ahead and stick your tongue in, back in your mouth. I am looking at her tongue. It does look pink. Say ah, just open your mouth. There we go. I'm looking around for her oral mucosa. Everything looks great. It's pink, moist, intact. Lift your tongue up for me. I'm looking under her mouth. I don't see any obvious nodules or bumps of any kind. Go ahead and put your tongue down. I'm looking at her dentition. Her teeth are all intact. I don't see any dental caries, no cracked, no bleeding gums, anything like that. So those are all the things that you're looking for to make sure. Tongue color, pink. If it was beefy red, it could be an B12 deficiency. I'm looking for any hairy tongue. I'm looking for any discoloration. If she is a smoker, I can tell that a lot of times because those patients get plaque or they get brown discoloration of the tongue, which in her case she does not have. So, and I would verify that with her history because again, I looked at her history before I came in. So that looks good. Her lips look good. They're nice and pink. I don't see any chapped lips. No bleeding, no discoloration there. I could also shine my pen light up into her nose to look at her nares. This is important to see if her nose is patent, if there's any drainage, discharge, blockage, deviated septum, anything like that, which she looks great. I could use my otoscope now, which I'm going to be very honest with you. Most hospital facilities, you may have them, you may not. Most doctor's offices do have them, so I could use them. But I would use my otoscope at this time, and I would, excuse me, look into her ears. Remember, for adults, we're going to grasp the pinna, pull it up and back to straighten out that ear canal. For children, we are going to pull the pinna. We're going to pinch the pinna just like we did for adults, but we're actually going to pull it down and back to straighten out that ear canal. So that's for kids, usually 3 and under. So adults, up and back. I'm going to look into her ear canal, and I am looking for a nice pearly gray tympanic membrane. I want it to be intact, no issues seen there, no drainage, no discharge, no crusting on the ear. I want to look for any signs of earwax. If it is present, I want to make sure that it's not obstructing anything. And in her case, her ears look, again, I would have my otoscope, but right now her ears look great. I don't see anything visible on the outside. Her appearance, like I said earlier, is nice. She is appropriate. She's clean. I don't see any signs of neglect. So she looks great. So that's all of my, that's all of my visual inspection of the head. Now, I could also go to palpation here. I could palpate the head, like I was speaking about earlier, feeling for symmetry, feeling for any nodules, any bumps, anything like that, which in her case she doesn't have any. I could also palpate the face, check for sinuses. I'm gonna palpate, since I'm in the head and neck region, I'm palpating for carotids, one at a time. And I'm so sorry, I forgot to mention, I could also visualize for jugular vein distension. Of course, I would set my patient up, and 30 degrees or more, there should not be any visible signs of jugular vein distension, and if there is, I would be concerned and want to schedule more testing for cardiology. But in this case, she does not. I can feel for my lymph nodes. Remember, lymph nodes should not be palpable, and if they are, we want to be sure that they are soft, movable. They're not hard and fixed, because that would be a concern. But in this case, she looks great. I could percuss sinuses as well. We could do our percussion if necessary. She looks great. I'm not concerned. So that is my head and neck portion of my head to toe. Moving from there, I would come down to my next body system, which is my chest. You can do this a couple different ways, but for me, I like to listen to lung sounds first. I like to do my lung assessment because it's easier for me to do lung assessment first, then do cardiac, because remember, with cardiac, there are more things I need to do for cardiac. I need to assess pulses, those kind of things. So for me, it just makes sense to do it this way. Some practitioners will do cardiac upper and then do cardiac lower. For me, if it's cardiac, I like to do it all at once, but it's totally your call as long as you get those body systems in. So for me, I'm going to listen to lungs, and I would grab my stethoscope and I would listen to 10 spots on the front, 20 on the back. So I would start about here. I'm gonna have my patient breathe in and out, and we come down in a, I like to call it like a ladder pattern, and we're gonna go, that's 4, 5, 6, 7, 8, back here 9, and 10 over here. So again, we're gonna come in this motion. So I'm gonna take my stethoscope. It would be in my ears, of course. Here, here, and in this number 5 pattern, all the way down. So 10 on the front. I would have her sit up then at this point. So Maria, go ahead and sit up. Move her hair out of the way, and of course, you always want to be assessing under the clothing. So, but of course, for demonstration purposes, I'm not going to have her take her top off or put her in a hospital gown. But I would have my stethoscope on, and I'm going to do, I did 10 on the front, 20 on the back. I'm going to assess the same kind of pattern. I like to start to the side closest to me, over, down, that 5 pattern all the way down. And when you're done with your assessment, you're going to come in such a way that you end up right about, if you stopped, I'm sorry, I can't feel her this way, but if you stopped right about here on this patient on the front, you're gonna stop right behind it on the back, so that you have your 20 spots on the back and your 10 on the front, okay? I would be assessing for when I did my vital signs, and I assess my radial pulse for heart rate. I would like to put my patient, I put her arm right about here, and I time her. I watch her chest rise and fall for a minute, and I then will feel her radial pulse for a minute as well, just for assessment's sake. When I'm assessing, remember, change in respiratory rate is your most sensitive indicator that there's a change in patient condition. So sometimes even if a patient comes in and they're breathing in that normal 12 to 20 range, if they've been 14 for the last 3 days and you come in now and they're 18 and nothing has changed, they're not doing anything, they're not up ambulating to the bathroom or ambulating in the hall, they haven't had a difficult conversation or anything like that, everything is exactly the same, they should be around that same range. So that 4+ jump in respiratory rate could indicate a change in patient condition. So I do want to be aware of that and accurately take respiratory rate, and it is that complete rise and fall of the chest. That's what I'm counting. Respiratory, what else am I doing with respiratory? So what else can I do? So what else I want to do here is I do want to percuss. I can percuss the lungs. Sorry, Marie. In the back especially, I do want to check. I skip palpation, but I'm gonna come back to it. If I had my patient sitting up, I would tend to do everything that I needed to do in the back if I have her sit up, so that I would have assessed for my, I would auscultate. I know that is not the correct order for assessment, that you should inspect, then palpate, then percuss, then auscultate. However, for me, I always auscultate first. It's just easier that way. However, you can absolutely follow the correct order, which you should, and palpate, percuss, and then auscultate. But since I have my patient sitting up, I would go ahead then and do all the things in the back. So I could palpate, I could feel her spinal process, I could feel down on the lungs, she could tell me if there's any discomfort. I could come down, I could check for expansion of her lungs. My hands will go right about here, have her take a deep breath, and then I'm gonna look and see. This is very important for patients that you suspect might have a hemo, a pneumo, or any kind of lung abnormality, like a collapsed lung, anything like that, so that I'm able to see that chest expansion, because as she expands, my fingers should come apart about the same width. If one hand is moving and one is not, that is definitely a problem. And because this is a bad angle, I would have her face me so that I could get proper expansion. She would dangle her feet on that side, but for visualization purposes, I want you to be able to see. I could also percuss. You can do direct percussion while you're back here and see, tap for any, you want to feel for air. We should be hearing air over the lung fields. You're going to assess for any crepitus. That's your palpation piece. And again, you should do this in a more systematic order of palpation, inspection, palpation, percussion, and auscultation. And I apologize that I did not verbalize that and show you that correctly. But I'm gonna have her lay back down, and then we're just gonna pretend that I did this in the correct order, and I would now palpate. I could palpate the chest because I've already inspected the chest, and again, she should be in a hospital gown, or at least have her top off. I would have already inspected for any lesions, any lumps, any masses, any discoloration, bruising. I would have also assessed for any scarring, anything like that come through. I can palpate the chest as well, especially if I felt like if I observed a mass or anything like that. I could palpate to make sure that it was movable, soft. And then of course percussion, you can percuss as well, and we'll percuss more and palpate more when we get to the abdomen, but that's next. So that's my respiratory assessment. I would assess for any adventitious sounds like crackles, rhonchi, wheezes, just to name a few. In her case, she would be nice and clear, which I've already assessed her and heard that earlier. Oh, that was attached. So we've done that. So now I would do her cardiac assessment. So I would go ahead and I would grab my stethoscope, excuse me, and I'm going to, I've already inspected again. I've palpated my carotids one at a time. I have palpated my radials. Now for me, because I'm on this cardiac palpation trajectory, I will have palpated there. I will check my cap refill for her fingers on both hands. I want them to be less than 2 seconds, which means when I push down, color returns within less than 2 seconds. So I've done that. Then I'm going to move down. If I was concerned, I could palpate in the femoral to make sure that she had a nice strong femoral on both sides pulse. However, I can come down here to popliteal. I'm going to check both sides here and here. Then I would come down, and again, I would do my posterior tibial on each side, my dorsalis pedis on both sides, and I would check cap refill of the feet. And that's what I would be doing there. I also, as I was doing that, would be inspecting for color, because again, if I'm doing cardiac, I think venous, I think arterial. So I want to check for color. I want to look at the legs. I want to make sure that there's no lesions, wounds, rashes, or any obvious discoloration. And I would also palpate them for temperature using the dorsal aspects of my hands. And I would also note any edema. So I'm going to take a finger and I'm going to push down right on top of that shin bone. And if she had any edema, it would, any pitting edema would be present. And if she did, I would note that in the chart. So in this case, that's what I'm doing for my cardiac. Then I'm going to come back up. So I palpated. Now I'm going to auscultate here, and I would put my stethoscope on, and I would listen to my patient in systemic order. So you're going to go feel for your patient. You want your second intercostal space. Sternal border, you're going to listen to your aortic sound. Then you're going to come over to your second intercostal space, sternal border for your pulmonic. Then down to the third intercostal space, sternal border for your herbs. Then fourth, left intercostal sternal border for your tricuspid. Then you're going to come down to your fifth intercostal space, mid-clavicular line for your mitral. Okay, we're going to listen to those spots for a heart rate. You should have S1 and S2 present. That's that lub-dub sound. Remember, your S1 is the snapping closure of your AV valves, and your S2 is the snapping closure of your semilunar valve, so your aortic pulmonic valve. So we're going to assess for that. So S1, S2 present. If you hear any adventitious sounds, it could be an S3 or S4, which is abnormal. So we have our S1, S2 present. We're going to be listening for rate and rhythm. And when I say rhythm, most rhythms you're not going to be able to identify unless you look at your rhythm strip to determine what it is. Do you have a P wave? Do you have QRS complex that is marching out regularly? Are they equally spaced? Those kind of things. But for example, patients with AFib, you can definitely hear that because that is a very irregular rhythm. So you can definitely hear that, and you can feel it as well when you palpate. Things like sinus tach, for example, if the heart rate's very fast, any kind of tachycardia, you can hear that. You may not know if it's VTach, SVT, something like that, but you can definitely tell if your patient's heart rate is fast because you're counting the rate as well. So we've done that auscultation for the heart. So thinking. Okay, so we've done all that. That's cardiac. Now, if this was appropriate for this patient, I would do a breast exam because, again, systemic order, systematically, I'm going to do breast next. In this case, I don't need to do that. She has no complaints. I would ask questions about, she is a young woman, so I would ask about sexual activity. I would ask about her menstrual cycle, breast tenderness. I don't think she hits that age range for mammography yet, but if she was 40 or over, I would ask about mammography, or if she had any history of breast cancer in her family, I would definitely ask about that as well. But in her case, she's good, there's no issues there, so I would move on. Go ahead and lay your feet out for me flat. Excuse me. So I would lay my patient down, so let me try and lay my patient down in this bed for her abdominal assessment. Let's see how this goes. All right, so abdominal assessment, I would, all right, can you pull your shirt up for me? Pull your pants out of it, perfect. So I would have to have the abdomen exposed, and I would look first. So I'm looking for any lumps, bumps, contusions. I'm looking for shape of the abdomen. I'm looking to make sure it's, flat. I'm looking for any bulging, so I'm looking for symmetry. Anytime, and like I like to tell my students, anytime there's two of something, you always want to be sure. So eyes, nose, ears, mouth, legs, all the things. So in this case, I have two sides to this abdomen. I want to make sure that they're both symmetrical. I want to make sure that she's breathing from her chest, not her abdomen, etc. So when I start my assessment for this, remember that you're going to listen. We're going to divide the abdomen up into four quadrants. I'm going to listen in each quadrant for 1 minute. And I'm going to go in an orderly pattern. I'm going to start at the right lower. So I would put my stethoscope in, and I would, with the diaphragm on my stethoscope, 1 minute in each quadrant. So starting at right lower, right upper, left upper, left lower for 1 minute each quadrant. And I'm listening for vowel sounds. If my patient does not have any vowel sounds in any of these quadrants, I have to listen for 5 minutes in that quadrant. So if I had no vowel sounds in the right quadrant, 5 minutes. And if there was none in the abdomen at all, it would be 5 minutes in each quadrant, which would be about a 20-minute abdominal assessment. So it is possible for that to happen. So remember, when we are assessing the abdomen, it does have to go in the order of inspection and auscultation before we percuss and palpate, palpate and percuss, because if I palpated this abdomen before I listened, I could elicit vowel sounds that aren't really there. So I want to listen first before I start pushing on her. So from there, in the same kind of general order I just went in, I'm going to go ahead and palpate. So remember, you have light palpation, moderate palpation, and deep palpation. In this case, I can use some deep palpation. I'm assessing for organs. I'm assessing for pain, tenderness, discomfort. I'm probably gonna come a little lower, but that's okay. I know your pants are in the way. So, I'm going to palpate. I'm going to palpate abdomen for any notable temperature change. I'm going to palpate for any discoloration I feel, any lumps, anything like that. I'm going to percuss. Percussion is the same thing. I can do indirect or direct. I'm going to use percussion to determine liver, borders. I'm going to percuss for sounds, elicit sounds, especially if my patient had ascites or anything like that. It would help me to determine what that sound is and determine that there is extra fluid on board, because sometimes that's difficult to see in patients that are a little obese, which in our case she's not. So when I'm talking about abdomen now, I am going to, I'm so sorry I can't sit you up. I would also ask her about her bowel movements, her bowel habits. I want to know how often she goes. I want to know about her diet. What is she eating? What kind of, is she getting enough fluid intake? And if she is, what kind of fluids is she drinking? This would be a great time to also ask about if your patient, are they taking any medications? Are they doing any recreational drugs? Anything like that, because that could all affect GI motility as well. So we're going to take a look at that. I would also ask her now, it would be a great time to talk about renal. Is she voiding? How much she's drinking, which we just talked about. What does her urine look like? Is there any odor, anything like that? We're gonna ask all those questions now as well. If I was doing a pap smear, because she is at this age, we could talk about that, get that, make sure consent and let her know that that's coming. I could also do that part of the assessment now if I wanted to, but in her case, we're not doing any of that. So I will ask her about her sexual habits. I'll ask her if there's any odor, discharge, or discoloration in her urine or anything, or discharge or anything like that. And again, I could reiterate about the menstrual cycle, those kind of things now as well. I could just restate what we've already talked about to make sure that I do have the correct information. Now would be a great time if she was an elderly patient. I would have her roll over, check her sacrum, and you always would want to assess perineum on your elderly patients. If you're in the hospital, especially, because they do have a tendency to have skin breakdown in those areas. So especially if they're incontinent of either bowel or bladder, which in her case she's not. I know it's comfortable for you to sit that way. Stretch your legs back out. So now would be a great time to finish out my neuro, because I've done a whole physical assessment on my patient. Now would be a great time for me. I do this last. Some people do neuro first. You can do its own special assessment. I like to chunk mine up, so I do mine last. So I want to check for strength, because it's musculoskeletal. I do all that last, and I can do the rest of my neuro that I did skip in the beginning last. So I'm going to stand in front of my patient, which I wish I could make this table. I would not have her legs up this far, because I would be a lot closer to her. Does it go back? Oh, perfect. Okay. Can you scoot to the end? All right, so I can check upper strength. So go ahead and give my hands a big squeeze, hard as you can. Good, good, good. Hold your arms straight out in front of me. Don't let me push you down, okay? Push against me. Good. So I'm checking to make sure that strength is equal bilaterally. I would pull her little table back out. I would have her lay back flat, and I would say, oh, okay, you're gonna do it, okay. Go ahead and lift your leg up for me. Don't let me push it down. Push, 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 push. Same over here. Don't let me push it down, great. Lift this one back up. Push against me. Good, okay. Oh, strong. This one, same thing. Okay. Now, push on my feet like you're driving push on my hands like you're driving a car, okay? Now the other way. There you go, good. All right, Maria, sit up for me. Good. So I'm checking her strength, make sure her strength is intact, musculoskeletal. If this was a patient in the clinic, I would make sure that she ambulates so I can check her gait, make sure that she's steady on her feet. If this was a patient in the hospital, I would check any PT, OT notes, make sure that they are seeing them if that was appropriate. And I could actually have my patient get up and ambulate too if it was a concern, but I would never ambulate a patient that I thought was unsafe. Let them just go willy-nilly on their own. I would absolutely always be with them to check for that. So, let's see, did we do everything? At this point, I did not do everything. I do apologize. I did skip the rest of my neuro assessment. It's all the cranial nerves, so we can't check just one. So I would ask Maria to close her eyes. I would pull out maybe an alcohol swab, something pleasant smelling. You don't want something that's nasty smelling. And I would have a cup of coffee maybe if breakfast was here. I'd have her close her eyes, and I would put something in front of her, ask her to smell. Of course, if she was able to identify the smell, that's cranial nerve 1. It would be intact. We check 2, 3, 4, and 6, which are eyes. 5, I would take my, I would have her give me a big smile. Okay, I'm looking for teeth again, symmetry. Go ahead and close your mouth, puff out your cheeks, smile, frown. She's not a good frowner, that's okay. But all of those are intact, so 5 is intact. I would, yep, sure would. Yep. I would have her, when I was doing her assessment of her face and I was looking at her mouth, I could tell that she was able to stick out her tongue. She moved it side to side for me. And she was also able to swallow. And now I could, if I was checking her thyroid as well, which I could have absolutely done while I was up in her throat area, I would have got behind her, had her swallow, and felt her thyroid. And that would also tell me that cranial nerves, let's see, where am I at? 8, 9, 10, 12, they're all intact. Then 11, she's able to push against my hands. So all of her cranial nerves are intact, so I could go back and do that. Or I could do them systemically as I am assessing my patient. The other thing you could do would be to do just your cranial nerves first if you wanted to. Totally up to you, as long as you get that in your assessment. So once I've collected all of my data from my patient, I'm going to make sure it's documented. I tell my group all the time, if it's not documented, you didn't do it. So I want everything documented, all of my findings, especially if I have any adventitious findings. In her case, she would not have any. I would document how the patient tolerated the procedure, and of course, anything that I wanted or recommended for her to do, if I wanted her to follow up with me again, if I needed her to go to referrals, anything like that, I would make sure all of that was documented and notated in the chart. And I think that's it for our assessment. I think we got a good picture of our patient. So, of course, I would ask if there was any questions. I would make sure she was in the lowest position, make sure she's nice and safe, and let her know what the plan was. So, thank you.